today we're going to start off by talking about the cardiac cycle. So far we've gone through the parts of the heart. Hopefully we know the order that blood goes through our different parts of the heart. We know about the electricity, the conduction system that causes the heart to contract. Now we're going to talk about just named parts of all these things kind of wrapped up together. We're going to see several lists for numbered phases, but some of these things should be familiar from our last couple of discussions. So when we're talking about the cardiac cycle, all we mean is that blood travels in a specific order. We hear specific sounds due to the event happening in the heart, and we expect specific relationships of pressure and volume in the atria and in the ventricles, as well as the arteries leaving the heart, specifically the aorta we're going to be paying attention to. So we can make a big map of all of these things and how they should parallel each other at different points over a cycle of one heartbeat. So that's what we're referring to when we talk about the cardiac cycle. Just all of the events happening in the heart through the course of one heartbeat. So when we talk about the cardiac cycle, the things we talk about most often in, like, if they daily life, right? It depends on what your daily life is. But the more familiar words should be systole and diastole. So those are our two main periods of the cardiac cycle, but these aren't going to be our phases themselves. But when we talk about systole and diastole, what we're talking about is whether the ventricles are contracting, that's systole, or whether they're relaxing, that's diastole. You could talk about atrial systole and atrial diastole separately, but that's never what people mean when they say systole and diastole. So really, we can just think about the ventricles, and really people mostly care about the left ventricle because that's the one pumping blood out to the rest of your body. So whenever they draw you a little graph of pressures, they've really measured that in the left ventricle. Ways to remember these words. I guess I think about systole as being kind of stressed because that's the clenching. Diastole comes from the same root as the word for like diameter. So if you think about the diameter as being like big and relaxed, that might help you remember its relaxation. So when we talk about systole and diastole, those two things are happening because of the actual muscle contraction controlled by those events of our conductive system that we talked about last time. But now that we're talking about the cardiac cycle as a whole, we want to layer on other things that are happening in parallel. So we're also going to be thinking about the valves. So the valves are opening passively due to pressure gradients, as we talked about on the first day when we were looking at the parts of the heart. So we're going to expect to see our atrioventricular valves, both the one on the right, our tricuspid valve, the one on the left, our bicuspid valve. We're going to expect them to open when the atrial pressure is high relative to the ventricular pressure, right? Because high pressure in the atria kind of pushes the blood forward, and those AV valves, they don't have any muscles within the cusps, they just passively open. The only time we see those papillary muscles active is to prevent the valves from prolapsing. Okay. So AV valves open when they have relatively high atrial pressure. The semilunar valves, those were the ones in the pulmonary trunk. So those arteries leaving the right side of the heart, and in the aorta, our artery leaving the left side of the heart. Those are going to open when we have relatively high ventricular pressure. So specifically because those valves are in the arteries, we're going to say that the ventricular pressure is higher than the arterial pressure, causing those semilunar valves to open. So we'll be tracing these through our different phases of the cardiac cycle. So we're going to have 4 phases. Okay. We're going to relate them to our ideas of systole and diastole, the contraction versus relaxation of the heart, but we're going to get a little more specific because we want to know the states of those valves. We want to know the relative pressures of the atria, the ventricles, and eventually the arteries as well. So our first phase of the cardiac cycle, since we are focusing on the ventricles, it's always helpful to think about the cardiac cycle, basically everything related to the heart, as how it compares to those ventricles. So we have our heart, going to have separation between our atria, ventricles, and between the ventricles and the atria. All right, so we have our right atrium, we have our left atrium, we have our right ventricle, we have our left ventricle. Okay. So we're thinking about the cardiac cycle with respect to the ventricles and their contraction and relaxation. So we're going to focus on our left ventricle as kind of what we're thinking about when we put these phases of the cardiac cycle in order. Okay, so our first phase is when that ventricle is filling with blood, right? So we start the cardiac cycle as the ventricles fill with blood. Okay. So technically this happens in the middle of ventricular diastole. So we're going to see at the end of this process, the ventricles start to relax, but they're not getting blood yet. It takes till this first phase of the cardiac cycle, halfway through diastole, that we start to have blood going from our atria to our ventricles. And this would be happening on the right side of the heart as well, because when we have contraction, our atria contract basically as one, our ventricles contract basically as one. So blood is flowing kind of in parallel down each side of the heart during that first phase. So what, well, it says it next. So let's think about the pressure here. So where do you think we are going to have high pressure during this ventricular filling phase? Where would we expect there to be more pressure? Yeah, exactly. So we're going to see that there's higher pressure in the atria than in the ventricles, right? So higher pressure in the atria, which means it's pushing into the ventricles, which means that these AV valves are going to be open, allowing blood to flow into the ventricle, because otherwise we couldn't have ventricular filling, right? If those AV valves were closed, no blood's getting in there. So blood's moving from the atria to the ventricle first, and it's not escaping yet. So our pulmonary and our aortic valves are closed, those arteries leaving the heart, because we don't have enough pressure in the ventricle yet, right? We've just said that it has relatively low pressure, and that's why blood is moving into it. So if it doesn't have high pressure, blood is not yet getting squeezed out into the arteries. So those valves haven't opened yet. They open just as blood pushes on them. Okay. So this ventricular filling phase is passive until the atria contract, but it does continue as the atria contract. So at first, we just have blood kind of slowly kind of leaking, and then the atria contract, blood gets into the ventricles a little faster. But since we're thinking about the cardiac cycle as being from the perspective of the ventricle, those are both still part of ventricular filling, still part of this first phase. Questions about ventricular filling yet? We are actually going to look at different parts of this diagram. So this is everything all together, but we're going to take a look separately at what the valves are doing, what the pressures are doing, and what's up with these volumes and heart sounds. So we will see this again, but I like kind of having it all together, at least at the beginning. Okay. So before I get to the next slide, what do you think is going to happen after the ventricles fill? What would have to happen next for our heart to get blood out to the body? If we move blood into the ventricles, what are we going to do next? Yeah, next we're going to contract. Okay, so our next phase is called isovolumetric ventricular contraction. Right, so we're starting to squeeze the blood. All right, so we've gotten the signal from our conduction system. So that muscle is starting to squeeze. So this is the beginning of systole, because systole is the contraction of our ventricles. So the part that's a little trickier is this isovolumetric part. Does anybody remember what that root at the beginning iso means? We've seen that tacked onto other words before. Like isotonic, we saw. So iso means same, okay? Basically. So this means we have same or equal. Probably it's technically equal. I'm not totally up on my, I assume that's Greek. But what this is telling us is that this first part of ventricular contraction, we don't have a change in the volume of blood in that ventricle yet. So what this is saying is that as we start to squeeze the ventricle, it takes a tiny bit of time before the pressure in that ventricle is enough to push out into the arteries. So as we start to squeeze at the very beginning, we still have lower pressure in the ventricle than in the artery. Okay, so that's what's happening here. Now, isovolumetric, right? So this is going to be related to the state of our valves as well. So you can think about this kind of as counterexamples. So if our ventricle were contracting and the AV valve were open, where would the blood go? So we're squeezing the ventricle, squeezing down on that blood, making the pressure high. Let's say we have this AV valve stuck open. Where's the blood going to move to? Yeah, it would move back into the atria if that AV valve were open, which is why we need to close it. We can't have blood moving back into the atria. So the pressure of that ventricle has gotten higher than the pressure in the atria at this point, which shut the AV valves. Our semilunar valves were already closed in that first phase. That's why we didn't have blood moving into the arteries yet. And during this phase, the isovolumetric ventricular contraction phase, even though the pressure in that ventricle is higher than the atria, it's still lower than that pressure in the arteries at this point. But you'll notice this doesn't last for very long, right? So our phase one is this chunk. Let's see phase two here. It's pretty little. And that is because pretty quickly, our ventricular pressure gets high enough to push those semilunar valves open, right? So this means that our pressure in the ventricle pretty quickly gets higher than the pressure in the arteries. And that means that we start to eject our blood from the ventricles. So this is still part of systole, right? We're still contracting the heart. It's just we've separated out our phase two of the cardiac cycle. We were contracting, but no blood was getting out yet. But now as we keep squeezing, keep raising that pressure, our blood starts spurting out, starts getting injected. So that's what's happening here during the third phase of the cardiac cycle, ventricular ejection. So as we move towards our fourth phase, we are going to see that as we have less and less blood, as we're squeezing out all that blood, at the end of this phase, that ventricular pressure is going to start to drop because pressure comes from this relationship between how much volume you have inside something, so in this case, how much volume of blood versus how much space there is. So as we move forward in the ventricular ejection phase, we have a small space because we're contracted, but we've ejected a bunch of blood, so we don't have as much volume in there. So we're going to see that the pressure in the ventricle starts to fall. Okay. This means that at the end of this phase, we're going to see the semilunar valves close because as that ventricular pressure falls, we're going to have a lower ventricular pressure than the pressure in the aorta, which means that blood is kind of trying to backflow. Okay. So we can see here that kind of change happening. So as that change happens, that triggers our onset of diastole, right? At the end of that squeezing, we've squeezed out the blood. We then start to relax the heart, decreasing the pressure even further. So our AV and semilunar valves are closed at this point. right? The AV, because they closed already and we haven't really put more blood into the atria yet. The semilunar valves, because we have that high pressure in the arteries now, because that's where the blood went. So this is isovolumetric ventricular relaxation, because both the valves are closed, so we don't have any blood moving during this part of the ventricular relaxation. Then we go back to the beginning, back to phase 1, where we had that ventricular filling. So yeah, so the ventricles are also relaxed during phase 1. Quick sort of checkpoint question. Thinking about isovolumetric contraction, what was going on? Okay, take another second to put in an answer. Take a look. Okay. So when we're breaking down this question, right, isometric volumetric contraction, you could memorize a list of things that are happening, but I don't like memorizing stuff that much, which may sound funny coming from this class. So we're going to look at the word, right? So we're thinking about a phase of the cardiac cycle. And we have here that this is a contraction phase. So we know that the cardiac cycle is telling us what's going on in the ventricles. So we cross out A, so that had atria contracting. B, C, and D, we have our ventricles contracting. So next we're going to look at that word isovolumetric. Right? So isovolumetric means we're going to have the same volume in that ventricle, which means we don't have blood escaping yet. Okay. So in order to stop blood from escaping, this means it has to be a closed wall, right? Like we have to be closed all the way around, otherwise blood is going to get out somewhere. So we know that our AV valves have to be closed, but if our semilunar valves were open, we would have blood escaping out into the arteries. If we have our AV valves open here, our blood would go back into the atria, right? So it's not that one. And here we have all those valves closed, so we have complete walls around that ventricle as it squeezes, which is why we don't have that change in volume. So that brings us to answer D, which is the correct answer. So here we see just a full picture of that cardiac cycle. So we can see at the top, they're showing us the flow of blood, right? So phase 1, we see that that's blood going into the ventricles, right? So into the ventricles during our ventricular filling. It happens both passively and then as the atria contract, we don't distinguish because we just care about what's happening to the ventricles. Then during the second phase, that isovolumetric contraction, you can see that that blood isn't moving anywhere, and it's all here in the ventricles. So we see these complete walls around the ventricles as we start to contract. The yellow arrows are that conduction system and that contraction. So you can see these yellow arrows telling us that the ventricles are starting to squeeze. Then that third phase, ventricular ejection, we can see that the main thing happening is that the blood is squeezing out through our arteries. So the atria contracted here in this first phase, right? So they emptied themselves of blood during this first phase of the cardiac cycle. which drops their pressure down. So that's part of why the blood doesn't go back into the atria. But as we move forward, we do start to have blood coming from the veins back into the atria while the ventricles are doing their thing. Yeah, they're starting to fill. So if we were to make up a cardiac cycle talking about what's happening to the atria rather than the ventricles, we would probably split it up different than that. That's why it's important to remember that this is from the perspective of a ventricle, because otherwise it does get confusing. We're going to zoom in on the pressure parts now. So these are all still going to be talking about the same phases. We're just going to be doing a deep dive on what's going on with our comparative pressures. So when we're looking at this graph, we're going to start with phase one. So phase one, I want you to note also on this diagram, they have phase one at the beginning and at the end, right? So they've kind of split it up. So what we can see happening here is that during that phase one, atrial pressure was rising as the atria are filling with blood. And then we had a little peak as the atria contract, right? So we see that happening kind of at the end of this phase one, right? And when we have that contraction of the atria, we can see this also causes a little bitty spike kind of in our ventricular pressure because we had the blood moving from the atria to the ventricles. But for this whole phase, so our green line is the ventricular pressure. So for the whole phase during ventricular filling, which is that first phase, the green line is below the red line. So the ventricular pressure is always below the pressure of the atria, which is why we have blood move from the relatively high pressured atria to the relatively low pressured ventricles. So next, during phase two, our isovolumetric contraction. So we can see that the ventricles started to contract here at the beginning of phase two. So you can see that this is a really rapid rise in the pressure of the ventricles because they're squeezing, and also because during this phase, the amount of volume in those ventricles isn't changing. So we have a really big difference in pressure because we haven't removed any blood yet. The atrial pressure here is falling because the atria have just squeezed out their blood into the ventricles and they're now relaxing. So they're doing their own kind of little cycle there. So that's what's going on with the atria. Now, during the third phase, the ventricular pressure gone up as we continue to contract. But once we have a bunch of blood ejected, this means that our ventricular pressure falls again, because even though we're still squeezing, there's not as much blood in there, there's not as much volume in there. And pressure has to do with this relationship between how much volume there is in an amount of space. Okay, so we go up, but we also go down. And the atrial pressure is still falling at the beginning, but then we can see that part that you noted, right? It starts to go up as we have a little bit of blood starting to come in once the atria are fully relaxed. I have really low pressure in there, which means that the pressure in the vein can kind of overcome it. We didn't look at phase four on this list of things, but phase four is just that we continue to have the ventricular pressure going down, this time because those ventricles are starting to relax. So because they're starting from a really contracted state, they are still higher in pressure than the atria until we move into the ventricular filling phase, right? And that's going to be what triggers this change from purely this isovolumetric relaxation to ventricular filling, right? Once we get low enough that we're lower than the atria, the blood starts to move into the ventricles. Okay. So when we think about systole and diastole, often the context in which we're thinking about it is with relationship to blood pressure, right? Systolic and diastolic blood pressure. And when we're thinking about blood pressure, what we're really thinking about is pressure out in the arteries and pressure out in the aorta, right? We measure it in the arm, but really it's all coming from the aorta. We just measure it in the arm because it's easy to get to, right? So when we're looking at systole and diastole, we want to think about what's going on in the aorta as well. So during diastole, so during the relaxation of the heart, the relaxation of the ventricles, our aortic valves close. So the aortic valve is what type of valve? A AV valve or a semilunar valve? Yeah, it's one of our semilunar valves. Okay. So the aortic valve isn't a new valve, it's one we've already talked about. So our aortic valve closes. We have our semilunar valves close. Blood is still leaving the aorta, right? So the ventricles are relaxed at this point. The valve is closed because we don't want blood flowing back into the ventricles, but blood still leaves the aorta because we want blood continuously flowing out to your body. We don't want gaps in the blood, the oxygenation, the glucose going to all your tissues. Okay. So this means because blood is still leaving the aorta, but it's not getting any new blood because we're not in ventricular ejection, the blood pressure in the aorta is falling during diastole. So when it's not getting new blood out to the arteries, that means the pressure in our arteries falls. Okay, so that's what's happening here. This blue line is the pressure in the aorta. Okay. Now you may note that we had a little diacritic notch at the beginning. So that is a backflow of blood slightly as the blood tries to go backwards at the end of systole. But after that, we have this blood pressure falling in diastole. Okay. This lowest point is where we would measure our diastolic pressure of the aorta. So the lowest point here, that lowest point of the blood pressure in the aorta. During systole, the aortic valve opens, right? So the aortic valve opens and blood is coming into the aorta, right? So this means this must be during ventricular ejection, right? Because that's what would open our semilunar valves. And we see a concurrent rise in pressure in the ventricles because they are squeezing that blood, and a rise in pressure in the aorta because it's receiving that blood. So as we're putting more volume into this artery, it has to hold more volume in that same amount of space, so its pressure rises. So that's what we see happening here during systole as the ventricle is squeezing. So we would measure our systolic pressure right at the top of this. So all we're measuring when we measure diastolic and systolic pressure is the peak pressure, right? So the highest pressure, systolic. So when we have the most blood going out into our cardiovascular system versus our diastolic pressure, how low we dip at the bottom when we don't have blood flowing out into the system. So the only other thing we might notice here, so I was mentioning here, is that diacritic notch, right? So right at the end of systole, we start to have that drop in blood pressure in the ventricle, or we start to have that drop in pressure in the ventricles because we've squeezed out all the blood. So there's a tiny bit of time where blood does flow backwards into the aorta out from the system as it's trying to escape into that ventricle before the semilunar valve closes. So that's all that is. So a value we're often going to look at as we talk about the cardiovascular system in the future is something called the mean arterial pressure, or MAP. And this is just going to be our average aortic pressure during the cardiac cycle. So as we talk about the cardiovascular system, we're not going to be separating out our systolic and diastolic when we're thinking about what's going on in an arterial. We're just going to be thinking about the average pressure going out to tissue. Okay. Now, this average pressure, this mean arterial pressure, is a measure of the force of blood moving through the systemic circuit. Right, so it's the average pressure in the aorta. The aorta is our big artery going out to all our organs and tissues. So this has to be what gets blood to those organs. Now, tricky thing, right, is that we have continuous blood flow to the systemic circuit during the cardiac cycle. But we don't always have blood going into the aorta, right? Sometimes that semilunar valve is closed. We're not always in ventricular ejection, right? The heart does relax. So we want to think about how that could possibly be true, right? Like, how is the aorta not getting blood, but it's giving blood out to the rest of the system? So it's not because there's muscles squeezing the aorta like there are in the heart. What it is an actual property of those walls of the aorta. So in lab, you may have noticed that the arteries and veins look kind of different, or at least you may have heard us try to convince you that the arteries and veins look different. So arteries, and especially large arteries, and especially the aorta, are really elastic. So their walls are going to be elastic. And what we mean here is a very specific physical property. And it is related to our common use of the word elastic, right? We do mean that they're stretchy, but what we really mean is that as they stretch, they're holding pressure kind of in that tissue, right? Like they want to snap back as they stretch. So when we say something is elastic, we think about it as holding pressure, kind of holding a force in it, because it wants to go back to the original state, right? So it's stretched, but it wants to go back, okay? So as we're in systole, as we're in this ventricular ejection phase, right, we're putting blood into the aorta, and to accommodate that blood coming into it, some of that blood is going out to the systemic circuit, but some of it is pushing the walls of the aorta open a little farther, stretching them. So we're stretching them because those walls are elastic, and they're holding that pressure there. Now, as the pressure drops, because we no longer have more blood flowing into the aorta, this means that the walls of the aorta can bounce back, right? So they close back down as the pressure in the aorta falls, right? This is what pushes the blood forward during diastole when we don't have blood flowing into the aorta anymore. It's this pressure of the elasticity making that aorta a little smaller in diameter. So it would look something like this, right? So in systole, right? So as the ventricles are contracting, that left ventricle is high pressure. So it's opened our aortic valve, one of our semilunar valves. We do have blood flowing to the systemic organs, but the blood is also pushing out on those walls. So they're pushing out on those walls, they're expanding, but they want to bounce back, but they can't because there's more and more blood coming in as we're still ejecting more blood here. During diastole, when we don't have blood coming into the aorta anymore, right? The first thing we had happen was the blood tried to get back into the ventricle because the ventricle relaxed and now with low pressure because it didn't have blood in there, but that closed those semilunar valves. So it can't do backflow. So we start to have this elastic recoil, right? Recoil bouncing back, which means that now we kind of have the tube of toothpaste thing squeezing the blood forward from the starting point of the aorta. Does that kind of make sense? We're just pushing back. Now, when we talk about elasticity, we're also going to talk in the future about a kind of opposite concept called compliance. Compliance. Which I'm just going to quick tell you about now because it is going to show up in some of the answers for some of the questions. So what compliance is compliant. If we call something highly compliant, what we mean is that it can fill with volume without creating this big change in pressure. So we think about something that easily expands, but doesn't have to be stretchy. So in the future, when we talk about differences between arteries and veins, we're going to talk about arteries as being highly elastic, as pressure reservoirs. We're going to talk about veins as being highly compliant and being volume reservoirs. So if you think about what a vein looks like, right? At least what we keep telling you a vein looks like, right? It's floppy, it's flat, it doesn't have very much blood in it in the cadavers. So something that's highly compliant, right, is kind of like a floppy empty balloon or something like that, right? It can expand because it's not really full, but we're not going to see a big change in pressure as it expands, right? So the aorta, as we put volume in, has this big change in pressure. Something that is compliant means that changes in volume without large change in pressure, which means that we're going to think about it as a volume reservoir. Hopefully I spelled reservoir right. I'm not very great at spelling, but just letting you know that now, because we have this kind of point counterpoint between elasticity and compliance. So we can also just kind of think of them as opposites of each other. Okay, so we're going to talk about our equation for finding mean arterial pressure, or MAP. So before we do that, we want to think about the heart. Do you think it spends more time contracting in systole, or do you think it spends more time relaxing in diastole? I'll note that those phases of the cardiac cycle we were looking at were kind of to scale. They were showing us how long each of those phases were as well. So if you look at which one is the longest on that little chart, this should give you a hint for the answer. So it's actually going to spend more time in diastole. So it's going to be relaxed more than it is contracted. So when we think about our equation for mean arterial pressure, we're going to remember that. We're going to have to make kind of a weighted average for mean arterial pressure. So we're going to measure a bunch of things about the heart, about the cardiovascular system. So one we're going to be thinking about is that mean arterial pressure, and we'll get back to that in a second. But I also want to think about some of the volumes we're going to be interested in. So we've been tracking where the blood is, but sometimes we're going to want to actually measure how much volume is in specific places at specific times. So one thing we want to think about is how much volume is left in those ventricles at the end of diastole. Right? So at the end of their relaxation, how much blood is in a ventricle, right? So do you think that's going to be a bigger number or a smaller number than the amount of blood they have at the end of systole, at the end of their contraction? Which one will be bigger, end diastolic or end systolic? Yeah, exactly. So end diastolic, that ventricle has a big diameter, it's relaxed, it's got a lot of space inside. So our end diastolic volume is kind of the maximum amount of blood we're going to expect to be in that ventricle. And the end systolic is going to be the opposite. We actually don't manage to squeeze every single little piece of blood out of the heart in every heartbeat. Some blood gets left in there. We don't create a vacuum in the heart. So we do have a little bit of blood left. So this is going to be kind of our minimum, right? Our minimum isn't 0. We have some left at the end. Okay. We care about these two numbers because we care about how much blood has been ejected. So that's going to be our stroke volume. So if we take the maximum amount of blood that was ever in that ventricle, right? So our end diastolic volume. So at the end of its filling phase. So at the end of the ventricular filling phase, right? That was the maximum amount of blood we had in those ventricles. And then we're going to subtract how much we have left at the end of the squeezing, right? So at the end of systole, at the end of the contraction, we still have a little bit of blood left. When we subtract that, that's going to tell us how much blood went out into the aorta during that heartbeat. So that's our stroke volume, how much blood is going out into the systemic circuit every time the heart beats. So all we're doing is subtracting maximum amount of blood versus how much is left in the heart. Well, practice was a little bit with numbers just to kind of narrow down on the concept, because we're going to see that stroke volume is going to be important for cardiac output, which is then going to be important for pressure out in the system in the future. Another way we can express some of the relationships between those numbers is by talking about the ejection fraction. So this could be clinically relevant, right? Not just how many milliliters of blood did you squeeze out to your system, because people's bodies are different sizes, people's hearts are different sizes, people do have different amounts of blood in their bodies. So just a milliliter number wouldn't always tell you something super useful. So sometimes we'll talk about the ejection fraction, like how much of your blood went out into the body. So to find the ejection fraction, we'd look at the stroke volume. So that would be like our milliliters of blood leaving the heart with a heartbeat, but we'd compare it to the maximum amount of blood you had in your heart, right? So this is going to give you a number that's more relevant to compare between people, or that you could compare to a chart, compare to what it should be, right? Because we're not going to have a very specific milliliter number that would be consistent enough to apply to everyone. So at rest, your ejection fraction, the amount of the blood in the heart that you should be sending out to the systemic circuit, should be about 54%, right? So here, the final thing we're looking at is changes in the ventricular volume over the cardiac cycle. So we can put this onto that same map as before. So we can see that as we were doing our ventricular filling, volume in the ventricle goes up. As the atria contract, ventricles are still filling. And we hit our peak right before the ventricles start to contract. So it's our end diastolic volume, because this is at the end of that relaxed phase. And then we see no volume change here during this phase. What was this phase called? Phase 2? Yeah, exactly. So it was isovolumetric contraction. Isovolumetric tells you in the name that we don't have a change in volume. So this is a little plateau there. Volumetric contraction. Okay. But during ventricular ejection, we fall and we reach a minimum volume of blood left in the ventricle. And that's our end systolic. So the difference between those 2 points, the high point and the low point, just tells us how much blood left the heart. So this is just that whole graph again, right? So we've talked about where the blood is. We've talked about the valves. We've talked about the pressures, talked about the volumes. And before, we looked at our electrocardiogram on Wednesday, so we can compare how that matches up to these phases as well. So what we will look at, we're at 12:34 already. So next time we'll pick up thinking about the heart sounds, and we'll have one more graph relating volume to pressure before we move into cardiac output. So next time we will introduce this lovely curve.